afternoon, everyone. We're very happy to be able to join you today. Kassandra and myself are both VA nurses too, and I've given several talks in the past years. This is probably one of the most special for me because I'm giving it to my VA nursing colleagues. So very, very happy to be doing this for you guys. I hope she won't mind me sharing the story. I actually saw Nancy Claflin after 20-some years. She was the nurse educator when I started my VA career in Phoenix in the early 2000s. So it's a pleasure to see her. It's a small community, but it's a strong community. So we're very excited to be here. Kassandra and I will be talking about nurse-led strategies in using PARP inhibition among veterans with prostate cancer today. The two of us, like I said, will be your speakers for the day, and we'll introduce ourselves at length as we go along. We would like to thank these entities for making this event possible, PeerView, ONCC, and Zero Prostate Cancer, AstraZeneca and Merck providing grants to cover the event. And we would like to encourage you to use your mobile phone to scan the QR code on the following slides. There would be a slide to complete the pre-event survey and to answer polling questions, as well as to submit your questions to us. And you will have a chance to win a prize. We will pick the top 3 questions. Each of those winners will receive a $50 Amazon gift card. So please scan that QR code, send your questions, and we'll try to cover them during the course of the presentation. You can also visit us at the website peerview.com/Virginia Beach 24, where you can view the slides, use the practic aids, and download them after the event. For more information, you can visit the website as well, live at peerview.com, and we are also active on social media at X@PeerView. So we'll practice with this question using the QR code. In your practice, which of the following represents a challenge to your decision-making for treatment of patients with prostate cancer? Is it 1, staying updated on data supporting PARP inhibition in metastatic cancer prostate settings? Managing adverse events, overcoming barriers to genomic testing, or providing specific needs for veterans? So our goals for today is to enhance your knowledge. A show of hands, how many of you are doing oncology right now? What about urology? All right, so even if you're not providing direct cancer-centered care to veterans, in one way or another, many of us in this room are caring for veterans for other reasons potentially that may also be having a cancer diagnosis or are undergoing cancer treatment. So it's very important to have knowledge of these things. We want to equip you with strategies on how to enhance patient education and provide guidance on how to use your interdisciplinary teams to optimize management. Again, I'm Grace Cullen. I'm the Cancer Program Senior Administrator at Detroit. I am also a nurse practitioner by trade. I specialize in hem-onc as well as palliative care. So why is it important? It's important because prostate cancer involvement is quite significant. In the United States, the estimate for this year is about 15% of newly diagnosed cancer cases will be that of prostate, and about 6% of deaths related to malignancies will be caused by prostate cancer. The median age at diagnosis is about 67, and it's a pretty, there's no good cancer to have, but this is one of those cancers that have turned into somewhat of a chronic illness, if you will. We are coming up with newer technologies, newer therapeutics that are prolonging survival longer and longer with less and less toxicities over time. And the 5-year survival rate, which means how long patients at the time of diagnosis until 5 years later are surviving, is quite high. It's about 97.5%. At the time of diagnosis, about 69% of patients will have localized disease, meaning it's confined to the prostate, and regional disease will be about 13%. So this would be potentially extension beyond the prostate gland, but within the immediate environment. And about 8% will have metastasis, meaning the cancer would have spread to distant sites outside of the prostate gland and its immediate surroundings, such as the bone, which is the most common site of prostate cancer spread, as well as lymph nodes. This is the 5-year relative survival. Again, localized disease, after 5 years, they tend to be alive, all of them, and regional disease also have a very high survival rate after 5 years. Those with metastasis, it's still fairly decent if you compare it with more aggressive cancers. About 36% of these patients will still be alive after 5 years. And what do we know about prostate cancer specific to the veteran population? Over 9 million veterans are currently receiving care through the VA system. And prostate cancer is the most common cancer diagnosis. It's a cancer unique to males. And as we know, majority of the patients we care for in our VAs are male veterans, although that number is changing. There's more and more female veterans coming up now. And prostate cancer is, outside of being the most common, makes up about 30% of the new cancer being diagnosed in the VA every year. Among veterans also, there's about 200,000 survivors and 15,000 new diagnoses every year. And most importantly, what may be unique to our veteran population, prostate cancer is a presumptive Agent Orange condition. So some of our veterans who were exposed to herbicides known as Agent Orange in Vietnam or Korea, this is one of the presumptive diagnoses is prostate cancer, for which they might receive service connection for. The cases of prostate cancer among military personnel is double that of the general population, and nearly 500,000 prostate cancer patients are being served by the VA healthcare system right now, and 16,000 of those have metastatic disease. This is an additional educational resource available to you as healthcare professionals as well as patients. Zero Prostate Cancer is an advocacy group dedicated to helping the care of prostate cancer patients who are veterans, their families, and healthcare professionals. They are rich in educational resources that you can refer to or refer your patients to. So what do we need to consider as nurses providing care to veterans with prostate cancer? Nurses have the opportunity to generate change in how we provide care in the VA for prostate cancer patients. We are at the front lines most of the time, so we know the patient beyond the diagnosis. We tend to know what support system they have. I always tell patients and colleagues, treatments are only effective if they're being taken. If for one reason or another patients are not able to take them, no matter how effective they were in trials, they're not going to work for that veteran. We need to get involved beyond the cancer care and have a better perspective as they undergo treatment, not just for them, but for ourselves. In order to educate, you need to be knowledgeable about what you're talking about too. So going to sessions like this one is very important. And counseling veterans about genetic testing, the use of targeted therapy, and opportunities to participate in clinical trials is very important. We only are able to learn about latest technologies because we are participating in clinical trials. I'm a clinical researcher myself, and as a young nurse, I never thought I would engage in research, but here I am. So please encourage your veterans to find out more about clinical trial opportunities available to them and educate them about those options. Targeted therapy and genetic testing is providing a lot of exciting opportunities in prostate cancer now. So what is the oncology nurse's role, and perhaps some of your roles too, if you're not an oncology nurse? We need to understand the mechanism of action of some of these medications, including PARP inhibitors, and to support patients during the course of therapy, which would also entail that you are knowledgeable about adverse effects and how to mitigate them. We need to keep in mind we are the gatekeepers. Those very profound, deep discussions that goes beyond the clinical arena usually happens at bedside with us at 10 o'clock at night, right? So we're very powerful in that, and use that power. We are essential for a team-based care. We are engaged in shared decision-making. We are providing education and resources to these veterans. The best decision, there's usually no right and wrong. It's a personal choice, I tell patients, but the best decision is an informed decision. So make sure you're knowledgeable before you make those decisions and provide those resources to your patients. Assessing them for benefits of therapy as well as adverse effects is also very important. So you have to monitor them and make sure that you're educating them on how to mitigate these adverse effects. Again, educating them on trials and addressing therapy-related concerns and barriers to treatment is very important. So education about clinical trials is very important because the more they know about it, the more they're comfortable about participating in it, the numbers of clinical trials will go up. And this would allow for more therapeutic opportunities to be available, and the finances associated with that is likely going to go down too. So at this time, I would like to invite Kassandra to introduce a case to us.
Sure, thank you. So this is actually a veteran patient of mine that I've known for close to 10 years now, and I've had a great experience with him. He is definitely a larger-than-life and vibrant personality that I've enjoyed. He originally came to Connecticut after he was told in the Florida VA that he only had 2 years to live. So he decided to come to Connecticut to live closer to his family. But as I got to know him, I was a new nurse practitioner at the time, and I always tell my students not to do this, but I did it. And I promised him that he would be alive longer than 2 years. Thankfully, as you'll see throughout this talk, the science actually was on my side each and every time he had a PSA recurrence, and he is still alive today and doing quite well. But originally in 2008, he was diagnosed with Gleason 8 prostate cancer, unfavorable, high risk, high volume, grade group 4 was in the majority of his sample. He was initially treated with radiation therapy. He was placed on long-term ADT. He had negative bone scans and CTs at the time, but you can see by the slide he did suffer PSA recurrence several times, but you'll see how some of these newer therapies really swooped in and kind of have extended his life and quality of life throughout his treatment course.
So we'll come back to her case in a little bit here. We'll talk some more about genomic testing and profiling and how it's used in targeted therapy and precision medicine and precision oncology among patients. So this is a graph here of what happens in the body as PARP inhibition and targeted therapy comes into play. So our DNase is a cellular structure that codes our genes. It's responsible for inheritance of traits and those types of things. It goes through a very frequent, repeated process of replication. And sometimes those DNAs take insults that results to destruction from endogenous and exogenous sources, such as medications, such as radiation exposure, or just the body's innate inability to actually replicate correctly. And we have proteins in our body that are smart enough to help with those repairs as the DNA repair structuring is needed. One of which is your PARP1 protein. For single-strand breaks, as you can see, there's 2 strands on the left and the right. If it's a single-strand break, that PARP protein is actually able to put a coating there and allow for sealing of that strand and healing. For double-stranded breaks, you need the BRCA protein, among many other proteins, to actually provide a good seal and repair there. So typically, when that repair happens in a normal fashion, then you are able to secure good health of that DNA structure in that cell. But if that repair mechanism is not working right, then the cell dies. So what PARP inhibitors does is actually to suppress the PARP1, right? It's good to have that good replication process if you're dealing with normal cells, but if you're dealing with cancerous cells that you don't want to promulgate, it's not a good thing. You want to suppress that activity. So what you want to do is to try to consider using an agent to work on your PARP1 protein. So PARP inhibitors actually suppresses the action of your protein PARP1, and it's not able to perform its function in repairing that single-strand break. And if it's not able to repair that function, the BRCA gene will try to still do its job, right? If that first-line treatment does not work or first-line event does not happen, that the single-strand repair takes place, then it results to double-strand breakage. The BRCA will then work to try to repair that double-strand break, and if you have a mutated, variated, or altered gene in BRCA, what it would do is to actually repair that cell in a normal environment. But if it's a BRCA incompetent or mutated gene, then that cell will die. So that's what PARP inhibition does. It's going to try to suppress the first line of defense using inhibitors to PARP1 so that the BRCA would not be able to repair a cell that should not be repaired, such as your cancer cell. There's 2 types of genomic testing that happens. There is what we call somatic testing, or checking for somatic mutation. So somatic mutations are genetic mutations localized to a tumor or cancer cell. It's not usually located throughout the body, whereas germline mutation is a mutation that happens throughout the body. And I tell patients and colleagues that a mutation does not equate to cancer developing. There should be a perfect storm, right, for cancer to develop, but it puts you at risk. There's about 30% carriers, but only about 5 to 10 of that translate to a cancer development. And why is it important? Somatic testing is important because it can guide treatment decision making, right? Like we talked about on the previous slide, we can consider the use of PARP inhibitors for patients who might show a BRCA mutation in the setting of cancer, including prostate cancer. And germline testing is something that they might carry and they might be able to pass on to their family members. So it's important for them to know, not just for themselves, but for their family members. So this is a graph of what I'm talking about when I say how it might be impactful to family members. For every 10 men, there's a chance one of them might be a carrier and might develop the disease that might respond to those agents, your PARP inhibitors and platinum chemotherapy. And there's a chance that carrier might not develop the disease but pass it on to their siblings up on the top or their children down on the bottom. And for siblings who are female, they might not develop prostate cancer, but they're going to be at risk for other types of cancer, such as pancreatic cancer, ovarian cancer, and breast cancer have been all associated with BRCA mutation. For the male patients' siblings, it puts them at a higher risk for actually developing the disease as well, and it tends to be more aggressive when they do. And similar risk for the children who are female and male, and how you mitigate those risks is by making sure they're proactive in getting screened, and that they're talking to their doctors about getting tested themselves. So we have found in many studies that if there's very limited use, even though the technology is there and there's a push to actually encourage its use, it's still not very used very widely. Only about 2/3 of patients are being tested, and of those being tested, only about 1/3 of them are actually being able to use this for therapeutics. So how do we assess for patients who might need this? You know, for germline genetic testing, your high risk to metastatic prostate cancer patients will be good candidates. Their ancestry might be something you want to consider, a positive family history of cancer, as well as family history of high-risk germline mutations. This is for patients with their own personal history of cancer, by the way. And then somatic tumor testing is recommended for patients who have metastatic prostate as a standard of care, and also recommended testing for microsatellite instability and mismatch repair is also encouraged. Reason being is because immunotherapy is something that we can consider using for prostate cancer with this instability in their genes. So we're going to revisit Kassandra's case. And at this point, looking at what he's undergone, it looks like he's had hormone suppression treatment done already, and unfortunately progressed to develop metastatic cancer. So might be a good candidate for somatic testing at this time, or even germline testing as well, combination of both. Although if you can see, as early as 2008, this patient would have been a candidate. He already had high-risk prostate at that time, but we didn't have the genomic technology at that time as rampant as we do now. So talking with veterans about the importance of testing, again, counseling them why we need it and what benefits they or their family members will derive from it is very important. We need to know why are they not wanting to participate, and we have to clarify misconceptions, provide reassurance that this is not going to impact their Agent Orange service connection. That's very important. The VHA just released a statement about that last year because there's been hesitation about engaging in germline genetic testing among veterans for that reason. So the VA already put out a statement, this should not have any kind of impact to agent service related service connection. For our own personal experience, we actually did a study on this. We had a very robust QI initiative to promote germline testing among our prostate cancer patients in 23 in Detroit. And what we found is it's effective when everybody has bought in on it. So every stakeholder should be engaged. But we found that even with our best efforts, about 8% of veterans are still declining to participate for these reasons that are cited here. So again, there's a need to counsel and improve our education of these veterans. Again, we would like to encourage you to scan the QR code for your questions and a chance to win the Amazon gift cards. And at this point, I would like to introduce Kassandra to give the next section of the talk.
Great. Thank you. Hello. My name is Kassandra, which I think we've established so far. I work at the Connecticut VA system in the West Haven campus, and I also am a professor at the Yale School of Nursing. So let's talk a little bit about some of the evidence for PARP inhibitors. So the FDA has approved several PARP inhibitors for the treatment of metastatic castrate-resistant prostate cancer. These treatments have demonstrated positive outcomes thus far in overall survival and radiographic progression-free survival. Some of the data is still maturing, but so far the data is really looking great for these treatment options. Olaparib was a trial that demonstrated improved radiographic progression-free survival and overall survival in previously treated metastatic castrate-resistant prostate cancer patients, and rucaripib in the Triton-2 trial demonstrated meaningful anti-tumor activity in patients and improvement in radiographic progression-free survival, and some of the overall survival data that's been released also showed improvement. So, looking at some of these charts, I know that we all were petrified of them in biostats, right? But here they are again. Here's all these charts. So these demonstrate the findings of some of the trials that have been done. So the PROfound trial was the one that researched monotherapy of olaparib. These Kaplan-Meier curves demonstrate radiographic and progression-free survival is significant between the non-treatment group and the treatment groups. Significant at the 12-month mark. There's continued significance if you can kind of see the difference when you look. Oh, here's my mouse. When you look at the differences in the curves, for sure there is a very significant difference. When looking at overall survival at 6, 12, and 18 months, the non-treatment arm demonstrated lower overall survival than the treatment arm. But of note, these researchers also noted that there was reduced pain burden and better preserved health-related quality of life compared with the control group. So that also is a significant finding when we're talking about different types of cancer treatments. So when you're looking at the Triton trials, you can see that there's a median time frame of approximately 9 months where there's radiographic progression-free survival. But in the BRCA subgroup, overall progression-free survival was estimated to be approximately 11.2 months versus the 6.4 in the control group, demonstrating this efficacy of PARP inhibitors in the setting of metastatic castrate-resistant prostate cancer with HRR mutations. Moving on here. So despite the demonstrated success of PARP inhibitor monotherapy, then the question became, hey, can we combine it with other therapies, and could that further impact our radiographic progression-free survival and overall survival time rates? And the thought process behind this was, hey, can we possibly have a synergistic effect of action for PARP inhibitors and androgen receptor signaling inhibitors? So then they began some of these other trials that started to look at some of the combination therapies for this. There are some significant differences between the trials. PROPEL and TALAPRO-2, the thing to remember about them is that when they started the trials, they began with no prospective HRR metastatic mutation selection, and all comers were eligible in the PROPEL in cohort 1 of TALAPRO. Then actually in cohort 2, they ended up transitioning to groups of patients that were HRRM from cohort 1 with an additional group of HRRM patients. The Magnitude trial prospectively evaluated all eligible patients, so they identified the patients and their HRR status before they were randomized. So they were able to also plan a futility analysis, which we'll discuss in a few slides. Niraparib and abiraterone, they were patients with HRR plus or without HRR-associated gene alterations in the groups as well. But these are all FDA-approved treatments for the treatment of metastatic castrate-resistant prostate cancer. So again, you know, what does all this mean? Back to our charts here. When you're looking at some of these Kaplan-Meier curves, you can see in the PROPEL trial, there is a notable difference between radiographic progression-free survival in the treatment arm versus the placebo arm. You can kind of see some of these significant differences in the arms of the trials. Regarding overall survival, patients in the treatment arm demonstrated an event percentage of 28% versus patients in the placebo arm of 66%. Later data, though, within the trial did, when they extrapolated the HRR positive versus HRR negative participants, continue to demonstrate that radiographic progression-free survival benefit in HRR positive populations, but less so in our HRR negative populations. So magnitude, when you're looking at the magnitude trial, you can see, and some of their data is still kind of percolating, but the radiographic progression-free survival was significantly longer. Futility was declared with no benefit, though, observed in patients without HRR alterations, that's one of the reasons why they prospectively identified them prior to assignment, so they could do that futility analysis, and it was found to have no benefit for patients who are HRR negative. Moving on to TALAPRO-2, they have identified that there is a 37% reduced risk of progression of death in this trial thus far. When you look at the 6, 12, and 24-month time points, you can see that progression-free survival there is a significant difference developing here among the curves. They also noted, though, in their study that the health-related quality of life was noted to stay the same for patients who are in the treatment arm versus the placebo arm. So we are at least able to maintain a patient's baseline health-related quality of life. And combination therapy with tazaloparib and enzalutamide is restricted to those patients with BRCA-M mutations and HRM mutations, respectively, at this point. So going back to our patient scenario, he was tested, and he did demonstrate HRR mutation as well as a BRCA2 mutation. So he was started on olaparib at 300 milligrams, and then we did increase him to 600 milligrams. We'll talk a little bit about the adverse events in the next couple of slides. We'll come back to that. So there are several side effects that you should be aware of with PARP inhibitors. So there are some common adverse events in the hematological, non-hematological categories. There are some really rare side effects that are very serious to note. But hematological adverse events are the most common cause of dose modification, interruption of therapy, and discontinuation of therapy. The top 3 hematological adverse events for PARP inhibitors are anemia, thrombocytopenia, and neutropenia. Fatigue was the most reported non-hematological adverse event. However, it's not really well understood why that happens. They think it possibly could be related to anemia, could be related to the malignancy itself, as well as previous cancer treatments. Diarrhea, indigestion, taste changes, nausea, and vomiting represent the most common GI toxicities associated with PARP inhibitor therapy. However, in systematic reviews and reported side effects, about 70% of patients only experience minor or mild adverse effects when coming to GI toxicities. So it was only a very small percentage who had severe GI toxicities. When you're talking about the rare common adverse events, myelodysplastic syndrome or acute myeloid leukemia occurred in only 1.2% of patients. But most of these events were classified as grade 5, which is why they are worth mentioning, but also occurred in patients who had received previous chemotherapy with platinum agents. Pneumonitis occurred in only 0.8%, so a small percentage of patients, but all the cases that were reported were fatal, so it is important to, when you have a patient who is reporting new respiratory symptoms, so dyspnea, cough, fever, should have their PARP inhibitor therapy either held or discontinued until you can further investigate that. So I put in the anemia grading slide just so that we can understand that there are different grades of anemia. So when you're talking about severe or life-threatening anemia, those are your kind of grade 4, grade 5 events, which can lead to discontinuation of therapy. But when you're evaluating anemia over all of the trials, about after 5 to 6 cycles, the incidence of grade 3 or higher was only about 25%. So most patients were able to remain on their therapy and manage their anemia. So when we talk about these events, the hematological events, it's also important to note there are several systematic reviews now that are published about the adverse events, but most of the patients receiving PARP inhibitors, it was mild to grade 1 or 2, and they tended to abate over several months if we could provide supportive therapies. But these are some of the management strategies that you can do. So monitoring closely, especially your CBC, to make sure that anemia is not occurring. Interrupting PARP therapy is an option, but we try to avoid that as much as we possibly can by providing supportive therapies. And in the event that a patient suffers a more serious adverse hematologic event, we may require discontinuation of the therapy or referring them to our colleagues in hematology. That's where Greece comes in. When you're looking at non-hematological adverse events, we talked a little bit about some of the GI toxicities. But we can support our patients by giving them antiemetics for nausea and vomiting. We can engage in treating them for stomach upset, dyspepsia, gastritis with some of our PPIs or H2 blocker therapies. We can also call on some of our complementary therapies, which we know some of our veterans subscribe to and some of them do not. I feel like there's not really a good middle ground with them for that. But ginger, acupuncture, which is offered at many of our VAs to mitigate nausea. CBD oils is of course, a supportive modality that you can. However, within the federal system, we unfortunately can't prescribe it. But there are some great veteran state local programs. In Connecticut, we have a really robust veteran program that they can be referred to on the state level. And of course, lifestyle modifications should be encouraged. So, decreasing irritative foods, eating smaller, more frequent meals or snacks throughout the day, and trying to take some of their medications with food to avoid some of the nausea and vomiting symptoms. When talking about fatigue, clinicians should be evaluating fatigue on a regular basis. Fatigue should be determined, though, based on the impact of the patient's quality of life. So are they able to carry out their pre-disease activities and the activities that they want to do on a daily basis? If fatigue persists, we should be looking for contributing causes. Anemia is, of course, one of the ones that's a recurring theme throughout these adverse events that we would want to be looking for. And also utilizing some of our programs. The MOVE program is a great program that is also offered throughout the VA system to get them engaged in some physical activity, which has been shown in some studies to help with fatigue in cancer treatment. Looking at hypertension and cardiovascular events, which we know a lot of our veterans already come with a lot of these comorbidities. So you would want to make sure that we are looking for these common manifestations of increased blood pressure, increased heart rate, grade 3 to grade 4 hypertension, arrhythmias, and possible QT prolongation. So just before we're starting the PARP inhibitor therapies, we would want to get a baseline assessment of these patients. And if they have some of these cardiovascular risks pre-treatment, then they should be well controlled and should be hooked up with cardiology at that point. But the incidence, again, of grade 4, or grade 5 adverse events was low overall, and most patients tolerated PARP inhibitor therapy quite well. So these next two slides outline the dosing and administration of PARP inhibitors. This slide summarizes the administration of rucaparib and olaparib. You get to learn all these tongue twisters for PARP inhibitors. It's important, though, to include in the patient education. You can see that some of these medications taken with citrus fruits, they should be avoided, so especially with olaparib. Again, this is another slide outlining the dosing combination therapies. I think the important takeaway for nurses is to describe these regimens to patients because making sure we have appropriate dosing and administration is so important, and a clear outline for patient families and for patients will help them to be able to continue their therapy in an appropriate and correct manner. So when I'm talking about pill burden, this slide is not meant to imply preference to one medication regimen over another, certainly not. All these medications have absolutely promising results for our patients, but the purpose of this slide is to determine which patient would be appropriate for which. I'm sure we all can think of patients off the top of our head who giving them 10 pills potentially may not be a good compliance regimen versus other therapies. So it's just taking into consideration that whole health idea that we try to promote throughout the VA and looking at the patient as a whole person and making sure that they are able to comply with their regimen. When we're looking at when to hold and when to reduce, most studies, the treatment time with PARP inhibitors was somewhere around 6 to 9 months. So there's a suggestion that most of these adverse events begin early in treatment and then abate over time. Also important to note that most of these studies were done with patients who had excellent ECOG scores, and I'm sure we also can think of patients who do not have excellent ECOG scores going into cancer treatments. So taking into account our patients overall and what adverse events they are experiencing, and this chart kind of outlines when we can hold or dose reduce to help with some of those side effects. So going back to our patient case, he was started on the PARP inhibitor. He did suffer mild anemia, which we were able to supplement him with PO supplemental iron, and he did well with. But his greatest side effect was fatigue and loss of appetite. He comes from a very extensive Italian family, so loss of appetite was a big thing for him. We tried supportive measures with anti-nausea medications, appetite stimulants, which did help him for a while. Every time we tried to increase him to the 600 milligrams, he started having intolerable fatigue. So he was one of the patients that had to be maintained on a lower dose. So he was able to stay on the 300 milligrams for quite some time, but it did take an effect on his pickleball playing. He's a very avid pickleball player. So he was very upset that he had to cut down from 5 times a week to 3 times a week. So that was a significant impact on his quality of life. But he did have some symptom improvement. This is to kind of show you that we can keep patients on therapy if we provide the supportive therapies that are necessary to keep them on therapy. The MOVE program, though, I can't say enough great things. We have such a great MOVE program coordinator in Connecticut. It's a great way to connect veterans as well to other veterans who are suffering the same thing. So good communication with our patients is important throughout their cancer journey, making sure we're evaluating as a team what's working for our veterans and what is not. Also just having some empathy and approaching things. People forget doses, people want to go on vacation and they forget their medication on vacation. So just having a validating and proactive manner in which we can kind of address the problems that come up on their cancer journey. The telephone triage, I'm a huge supporter of nursing autonomy. I think telephone triage is such a great way to implement this. Appropriate evaluation of symptoms can help distinguish what patients need to come to the clinic versus can be managed at home. And most patient complaints can be managed and determined actually by a good patient history and through evaluation of symptoms, which I tell my students all the time. If you ask the right questions, you can actually get a lot done by asking the right questions. So this is a great resource for telephone triage of some of these complaints that patients can call with on PARP inhibitors. Multi-professional teams, I think one of the things I enjoy most about working at the VA is that they have promoted these collaborative teams for a long period of time. One of the things I love about our urology department is I do really feel like we call on each other's strengths and weaknesses when we need to. But it is really important to our patients' cancer journey that we are all kind of working on the same level of care for them, and collaborating gives us this way to positively impact their cancer journey. So just remembering that we're all really important pieces of this team will help us get these patients to the treatments that they need for their metastatic castrate-resistant prostate cancer. And finally, we have our educate, emphasize, and equip patients. The Zero education is such a great resource for our veterans. There's tons of places to get information to them. But it is the nurse's job and the nurse practitioners and hopefully our physicians as well to provide this education, emphasis, and equipping them with information each and every time we make contact with the patients. Our nurses are such an important part of the team. Oh, I went back too far. I always tell my students that nurses are like the goalies in soccer. You're the first line of offense and the last line of defense. So you definitely are there to provide all of the education, support, communication, and sometimes therapy that patients need during their treatment. Okay.
Yep.
I will hand it back over to Grace.
Yeah, so again, we would like to remind you these are resources available to your patients. Zero will have a lot of educational resources available to patients as well as healthcare providers and families as well. In summary, what does this mean for all of us at this point? What do we walk away with after this is done? So PARP inhibitors have transformed clinical care for patients with metastatic cancer of the prostate. Biomarker or germline or somatic genetic testing is imperative for your patients. All patients with metastatic prostate cancer with BRCA1 or 2 alterations, variations, or mutations, those terms sometimes are being used interchangeably, should be receiving PARP inhibitor monotherapy after having had disease progression on a previous androgen receptor inhibitor. Or it can be combined with an androgen receptor inhibitor as a first-line treatment. And keeping in mind, too, as Kassandra said, there are side effects associated with them, so you want to tailor it to the right patient, too. Whether you're doing doublet or triplet therapy, the patient has to be the right age, the right performance status, with the right comorbid conditions as you consider what kind of combination to use. Different issues may arise with PARP inhibition and various combinations, just like I said, so be aware of the adverse event profiles and adjust doses as needed. Prioritize clinical trial enrollment for all of your patients. You don't have to wait until they don't have any choice. Try to encourage it as early as possible. This is how we are learning about new therapeutics, is through these trials. Educate your patients, caregivers, and as well as your colleagues. They will have questions about these new experiences. They will likely ask you those questions, likely not the doctors. They're likely going to be more comfortable approaching you, so be educated and be prepared to answer them. Again, scan the QR code, send your questions over. We'll be taking them. I think it's time to actually start taking them now, so we can go over them now.
Yeah,
and as a reminder, 3 of you will win the $50 Amazon card. So I can start with the first question. This is from Enzo. Some of the veterans were hesitant to try new ways to diagnose and manage prostate cancer, maybe due to multiple factors. How can we advocate or convince a veteran to sign up for genomic testing to help identify their risks or types of genetic mutation that can be beneficial in developing a patient-centered treatment plan? So, like I said, first step is know well about it. That way you can share the information with the patient. A lot of times I encourage them by telling them this information will be useful to you for therapeutic purposes, but you are doing your family members a favor too by finding out about this and letting them know about this so they can be proactive in their own screening. PARP inhibitors tend to be also less toxic than chemotherapy. So if patients are given the choice of going into PARP inhibitors versus chemotherapy, a lot of times patients will choose PARP inhibition before choosing chemotherapy. And it's covered. So it's not, it's something standard of care for the VA. If they're a veteran, it's covered. And most private insurance companies cover them now too.
Mm-hmm. I think that's a good bridge into the what tools do we currently have. To a question from Shannon, it says, what tools do we have currently to educate patients on the benefits of safe practices adhered to regarding genetic testing? Is there approved language taught to primary care? How can we promote this discussion with primary care, and is it appropriate? I definitely think collaborating with our primary care colleagues is so important to get patients familiar with the idea of some of these new genetic testing. If your VA is not already hooked up with it, the collaboration between Seattle and the Salt Lake City VA, they do a lot of our genetic testing. They have wonderful genetic counselors who can have that discussion with the patient so it doesn't fall completely on providers. They also do a lot of training. So I think 2 or 3 years ago, they did a big thing where they were trying to educate a lot of the providers and nurses on what genetic testing meant and how we do it through the VA. So there are a lot of resources available through the VA actually to help kind of promote that discussion. But definitely starting the discussion is always appropriate, I think, in primary care, and then falling on our colleagues to kind of draw in that collaborative team to get patients to genetic testing is certainly a good plan.
I agree, and I think it's worth mentioning too, what was brought up in that question too is the lingo, right? The word mutation tends to turn off a lot of patients, so using the word variation or alteration might be something that will be more welcoming to them. It doesn't make them sound abnormal or have an abnormality that they were born with or carrying with them. Which segues very well to the next question: is the testing covered? And if so, does the percentage of service connection affect the cost? So this is covered. This is standard of care for certain types of prostate cancer now. High risk, very high risk, and metastatic prostate cancer are expected to include genetic testing as part of the care. If you don't have the services available at your local institution, there's an inter-facility consult you can place for genetic counseling, so you can start off with that. If they're unsure, you're unsure, refer them to that group, and they have genetic risk assessment specialists that can go over the pros and cons with the veterans and determine whether they're good candidates for testing, and then take it from there and actually implement the testing. There's also an interfacility pharmacogenomics consult, and this is going beyond the cancer realm. I know they're starting to use this in hyperlipidemia, in diabetes. So you can actually brainstorm with that group too. That would include clinicians and pharmacists to find out whether certain therapeutics might work better for certain patients.
When you talk about service connection too, there's a good one. Is prostate cancer related to burn pits as well as Agent Orange, or are there other service-related connections to prostate cancer? As of right now, Agent Orange is the one service-connected condition. I know that there's been discussion and talk, especially with the Camp Lejeune changes, of potentially adding prostate cancer to that list. It just hasn't come through in the legislation yet. Burn pits, oh my goodness, burn pits. I think that we're going to learn so much about exposure to burn pits in the next 10 years. I definitely encourage my patients, if you're not on the burn pit registry, to get themselves on the burn pit registry. One of the ways that we learn about things that are happening to our veterans are through these registries, so that we can provide them the care that they need and also push for the legislation that will cover those diseases. But as of right now, it's not on the list for burn pits, but definitely getting those patients on the burn pit registry, I think, is a huge priority in making sure that they're there. And remembering that those veterans who are exposed to burn pits can range in age from 19 to, I think, like 50 now. So it's a wide range of exposure to burn pits. So always asking the question is important to get them on that registry.
Question from Rick: how do you see your practice changing to deliver prostate cancer treatment in the future? If you remember that slide that actually traced the history of the patient that Kassandra presented back in 2008, he had high-risk prostate cancer. But because genomic testing technology was not widespread at that time, he actually ended up using other agents, did not get testing done that probably would have made targeted therapy available to him. So there are more options available to patients with prostate cancer now. They're less toxic, and it prolongs the time between the time of diagnosis to the time they have to start on chemotherapy, which is really something that patients are very happy about.
Yeah, that's a great segue too into if PARP therapy is effective for a patient, is the therapy they will need for the remainder of their life. This is still a question that's open. Some of the studies are still looking at long-term data. So if you see on some of the Kaplan-Meier curves, they stop at 24 months because they're still developing some of that data. So there are some patients who've been on it for a long period of time. So, if we remember our bell curves, you're going to have the patients that fall on the very short end versus the patients that will be on the very long end. So this is not an answer that we currently have, but hopefully it will be a long-term therapy that we can use to continue to prolong their life. And thus far, there are some patients who have been on it for 2 years at this point and still have effective therapy. So still developing. That question is still, the answer is still developing.
From Ellie, with neutropenia being listed as a hematological adverse effect, does that render immunosuppressive candidates as ineligible to take? So I would say to that, it depends on the degree of neutropenia. So we have certain parameters too. Usually in the setting of neutropenia at the range of 1,000 or less, we will hold treatment. And we may consider re-challenging that patient perhaps at a reduced dose. It's found that up to a point of 50% dose reduction, a lot of these agents will continue to be effective. And I think I would throw into that basket too, outside of neutropenia, look at your patient too, right? What other side effects is this patient having? You know, fatigue is very big in the cancer world. A lot of patients would ask to be taken off treatment because they are not able to enjoy the quality of their life. And I tell patients, when we are assessing for a treatment response, we're not just checking your scans, your PSA number, we're checking how you're feeling. Because if those things are improving, but you're feeling bad, it's really not achieving its goal. Treatments are supposed to help improve your quality of life. So treatment holidays are not unheard of if that would allow patients to actually stick to the regimen a little longer by taking little breaks. And I always tell them too, you are in control. I think that's the biggest obstacle patients and family members face when dealing with cancer, is that the sense of lack of control. We are telling them when are they coming in for appointments, when the next scan is. And every scan is very anxiety provoking. They're praying for weeks that that scan is stable, if not improved, right? So allowing them to live life. I tell them we're having the difficult discussion now. We have a plan. Go home and live your life to the fullest, because none of us know. You know, it could be me tomorrow having an issue. But let's live your life to the fullest. We have a plan. We'll carry out that plan. But most importantly, we have to promote the quality of your life, however long or short that may be with the treatment that we have. And again, treatment that would work is only a treatment that can be taken. If a patient could not tolerate it, no matter how good it's doing in clinical trials, it's not going to do anything for that patient.
Yeah, I think that's an important point to make, and I always tell my students when they're shocked and they have the wide-eyed scared look when I tell them this, but the option to do nothing is an option, and I think it's important, especially in terms of treating patients with cancer, to let them know that even if their choice is to do nothing, we're there to support them. So I think that that's an important piece, is recognizing that sometimes discontinuing cancer treatment is what is best for the patient, and that we're there to support them and give them the information that they need to make all decisions, including as many advanced treatments as they want versus, you know, the option to do nothing.
True. Or also educating them that, you know, not pursuing treatment is usually not something that equates with doing nothing. You're just doing something that you choose to be different from pursuing treatment. And again, it's a personal choice. And there's a lot of times no right or wrong decision. When somebody's making a healthcare decision, it's a very, very personal decision. I've had veterans, you know, like we said, this is a diagnosis that tends to occur at the median age of 67. By the time metastasis takes place, it takes about 5 to 10 years from the time a local disease is diagnosed. So many of our metastatic cancer patients are being diagnosed with mets in their late 70s, early 80s. Many of them may be caregivers to their spouses too. So there's a lot more of a concern to them than what you are seeing in your practice, in your scans, in your numbers, right? There's a lot happening at the home that can influence those decisions.
Are PARP inhibitor treatments exclusive to prostate cancer? If not, are their treatments more effective in certain cancers? PARP inhibitors are also being investigated in breast cancer, ovarian cancer, I believe, as well as prostate cancer. So they are being studied in those populations too. They're finding that these treatments are more effective in our HRR positive and BRCA mutation patients. You're the oncology parent, if you have more to say on that.
Yeah, that's correct. And what we find in oncology is that the indication for many of these drugs continue to expand. Immunotherapy initially started with non-small cell lung cancer, and now it's being used for a lot of different types of cancer. Yeah. So work is out there to continue to find, you know, ways to use targeted therapy in many kinds of setting and many kinds of diagnosis. From Sonia, as a non-oncology RN, is there any specific care to be taken in the administration of these drugs? So I'm not sure if that's as far as whether they're considered to be hazardous substances or whatnot. So PARP inhibitors are not considered to be hazardous, so you don't have to wear special gloves or dispose of things any special way. But I think just being aware of what those potential adverse events are, just because it might play a role in acting together or with other comorbid conditions, right? Hormone suppression can lead to worsening of existing cardiovascular diseases, as well as endocrine diseases. So patients with underlying hyperlipidemia, hypertension, and diabetes, I counsel them that you have to work closely with your primary care, with your cardiologist, because when I put you on these hormone treatments, there's a chance that I might worsen those conditions for you. So as a primary care nurse or whatever setting you're working at, like I said, even though you're not providing direct cancer-related care, we count on you to help us. Because once I see that patient for a 3-month injection, I may not see that patient again for many weeks, and they might be seeing you in the interim, so we need your help.
I think there's one more, and then our cue.
When it comes to anemia, from Jenny, how many bags of blood products is too much for management? So it would depend on the degree of anemia, and it would depend on your patient, right? A lot of times, right now, we used to just transfuse everybody under 8, right? When we started having scarcity of blood products, we said, maybe we have a threshold, we can start considering that for a hemoglobin of 7. So 7 usually is for a general rule of thumb for most patients. If you have a cardiac patient who's symptomatic, we might bump that up to 8. But again, it depends on the patient and what the circumstances are. But for the most part, those are the parameters for transfusion. And again, if you think it's your drug causing that, then you have to reassess how you move forward too. All right. So at this point, we would like to invite you to please complete and submit your post-test and evaluation for credit. You can download the slides and practice aids at that website. Feel free to email us. My email is my name @va.gov.
Mine is the same. It's a hyphen, not an underscore, at va.gov.
I guess we may have another minute or two available. If there's any, 2 minutes, I was told. So if anybody else has any questions, there is a mic that's going to be circulating in the room.
Hi, thank you for that great presentation. I had actually submitted a comment there. My name is Andrea Kasuji. You'll be hearing a little bit from me tomorrow. I work for the War-Related Illness and Injury Study Center. So just wanted to clarify 2 different things that were discussed today. One is the Airborne Hazards and Open Burn Pit Registry. It recently underwent redesign, very recently. It was put out by VA News back in August, that it is now actually opt-out. So anyone that actually served in these very specific designated areas during a specific period of time are actually automatically in the registry.
Oh, good.
So that is good news.
Yeah, that's great news.
And the other piece was the PACT Act, specific to burn pit-related cancers and presumptive conditions. And prostate cancer actually does fall under a presumptive condition, male reproductive cancer, for burn pits. So
good to know.
There's hundreds of different presumptive conditions. It's really difficult for most clinicians to keep up on this. And some of it is kind of fine print. You have to know exactly where to go and where to look. So just wanted to clarify that for all of you who actually work with veterans who have these concerns. And again, you'll be hearing a little bit more from me tomorrow on how you can learn more about this. Thank you.
Wow, that's good to know. Make VBA busy.
Okay. So I made a comment. You guys didn't read it, but that's okay. You guys mentioned something along the lines of veterans are 50% more likely to be treated for prostate cancer. So my question was, is there some sort of research or anything being done to see, is it more prevalent for veterans, or just that civilians aren't treated for it as often as veterans are? Is there a reason veterans are getting prostate cancer more than civilians? Is really my question.
I think there are multiple factors that come into play with that. Certainly exposure to Agent Orange is likely unique to the veteran patients than it would be for the general population. I think there's a very strong push for screening in the primary care setting as well. Our primary care providers are usually very good about following cancer care guidelines on when to screen. So PSAs are being done routinely as opposed to the private sector, and that's why detection is higher also.
Also, if you look at some of the data on social determinants of health in the civilian sector, when you start to extrapolate and look at different access levels to care, that impacts prostate cancer treatment significantly. So we talk a lot about that with our students in terms of when you're accessing care, looking at social determinants of health, whereas we don't really have as many of those issues within the VA system. We're kind of like a mini version of socialized medicine, where we're able to kind of provide that equity of care to our veterans. So that's also something to keep in mind as we move along.
All right.
We got to wrap it up.
Well, we are out of time, but we will be available in the sidelines if you have any questions. Again, you can email us. Thank you very much.